أعرفكم على type 1 diabetes relation to the other autoimmune diseases. I have no conflicts of interest to disclose. My patient is AHA. He's a 16 years old type 1 diabetic patient. He was diagnosed 6 years ago. His initial presentation was DKA at the age of 10 years. His fasting C-peptide was 0.1 nanogram per milli and anti-GAD antibody was 81 unit per milli. He was diagnosed as type 1 diabetes and he was given a basal bolus insulin regimen on a dose of 1.3 unit per kg per day. He was controlled on it and his hemoglobin A1C was 5.8%. 3 years ago, on March 2017, the patient developed generalized lymphadenopathy, polyarthritis with spiky fever. Abdominal examination revealed hepatosplenomegaly with a liver of 5 centimeters below the costal margin and a spleen just palpable below the costal margin. His investigations revealed a first-hour ESR of 90 millimole per hour. Rheumatoid factor was negative. C3 and C4 were not consumed. His DNA was positive speckled pattern, while his anti-DNA was negative. His pelvic abdominal ultrasound revealed hepatosplenomegaly with right external iliac lymphadenopathy, with preserved hilum and normal vascularity. The slit lamp showed no uveitis. What do you think? We thought of the patient as a patient of systemic onset GIA, and we started ibuprofen on a dose of 30 milligram per kg per day. There was no improvement, clinical or laboratory. 3 months later, the patient developed parotid and submandibular sialodenitis. Neck ultrasound showed bilateral submandibular glands, heterogeneous appearance, mostly inflammatory. So we started first antibiotics for 2 weeks with no improvement. And then we did lymph node biopsy, which revealed chronic lymphadenitis with reactive follicular hyperplasia together with periadenitis. We did the anti-Sjogren syndrome antigen A and the anti-Sjogren syndrome antigen B. They were strongly positive, both of them. So he was diagnosed as primary Sjogren syndrome. 2 weeks later, the patient developed pallor with epistaxis. His CBC showed him anemia with hemoglobin of 7.4. It was normocytic normochromic with platelets, with thrombocytopenia and a platelet count of 24,000. His reticulocytic count was 7%, and his direct and indirect Coombs were positive. His bone marrow aspect was normocellular with no evidence of neoplasia. So he has event syndrome or autoimmune anemia and thrombocytopenia together with the Sjogren. We did echocardiography was normal, and his 24 hours urinary protein was showed microalbuminuria. His thyroid profile was normal, and his antithyroglobulin antibodies and antimicrosomal antibodies were negative. The patient was diagnosed as primary Sjogren syndrome with immune-mediated anemia, thrombocytopenia, and autoimmune diabetes, and started steroid in a dose of 1 milligram per kg per day. Then the patient developed persistent hyperglycemia on the steroid. So the insulin dose was increased, reaching a total daily dose of 1.5 unit per kg, on which the blood sugar was controlled. Follow-up after 1 month showed improvement of the arthritis, the sialodenitis, and the cytopenia. On April 2018, his ESR decreased to 25 millimeter per hour. His hemoglobin was 10.7 and his platelets 184,000. So the steroids was tapered to 0.5 milligram per kg per day. Unfortunately, on October 2018, he developed subcutaneous abscess in the abdomen on the injection site. It led to flare-up of the autoimmune process with high-rate fever, arthritis, increase of the ESR to 90, and the CRP was 48, hemoglobin decreased to 8, with a retex of 5% and the platelets of 50,000. So we gave antibiotic to control the infection. We did immunoglobulin profile, which was normal, and CD markers, which was normal. After infection was controlled, the patient was started on azathioprine on a dose of 3 milligram per kg per day, together with the corticosteroids, 0.5 milligram per kg per day. On October 2019, the patient was complaining of persistent hyperglycemia with a hemoglobin A1C of 10.5%, and he was on a total daily insulin dose of 1.9 unit per kg per day. So he was started on insulin pump therapy. That's his CGM report before the insulin pump insertion. It shows frequent excursions with 30, the time in range was 31% only. After the insertion of the insulin pump, that's his follow-up CGM, with the time in range increased to 63%. That's his follow-up on March 2020 with an A1C of 6.9%, total daily insulin dose of 1.5 unit per kg per day, hemoglobin 10.5, platelets 175, and ESR 15. On September 2020, the A1C increased slightly to 7.8 with the COVID era and staying at home. His total daily dose was still 1.3, hemoglobin 10, and platelets 190, and ESR is 5. Diabetes is the most common chronic metabolic disease diagnosed in children and adolescents. Type 1 diabetes, as you all know, it's an autoimmune process. It has been evidenced that the development of type 1 increased the risk of other autoimmune diseases. The autoimmune process progressing into pancreatic beta cell can also affect other organs. It can lead to organ-specific autoimmune diseases, like autoimmune thyroiditis, or non-specific organ non-specific autoimmune diseases like the GIA and Sjogren syndrome. Multiple papers studied the relation between autoimmune diabetes and other autoimmune diseases. The relation between Sjogren and type 1 diabetes, only one paper studied this. It was by Binder et al. In 1989. He studied 102 type 1 diabetes patients. He showed that symptoms affected 55% of his patients, although symptoms only occurred during the hyperglycemic phases. The frequency of ANA in those patients having Sjogren was 25%, and anti-Ro antibodies was 32%, reinforcing the suspicion that Sjogren syndrome may underlie their presence. From this, we conclude that further studies should be done to explore the relationship between primary Sjogren, autoimmune diabetes, and autoimmune cytopenias, and physicians should be aware of the possibility of autoimmune cytopenia and Sjogren in patients with autoimmune diabetes. Thank you.